to all the diseases. You may get an essay question in the sexually transmitted diseases, or sometimes they may ask the short notes in the syndromic approach of the sexually transmitted diseases. Okay, the definition for the sexually transmitted diseases are: it is a group of communicable diseases which are transmitted predominantly by sexual route. They are also called as venereal diseases. Previously, they used to call as a venereal diseases. Now, the word venereal disease is changed to sexually transmitted diseases because the disease is predominantly transmitted by the sexual contact. Here, if you see the causative agents regarding the classification of sexually transmitted diseases, there are bacterial, viral, protozoal, fungal, and ectoparasite. So, five types of classification of the sexually transmitted diseases: bacterial, viral, protozoal, fungal, and ectoparasite. Under the bacterial agents, there are Neisseria gonorrhea, Chlamydia trachomatis, Treponema pallidum, Haemophilus ducreyi bacilli, and then Mycoplasma hominis, and Uroplasma urinalicus, and Calmibacterium granulomatis, Shigella, and Campylobacter bacteria, and then Group B Streptococcus and Bacterial vaginalis. They are all they comes under the bacterial agents. Under the viral agents, human that is herpes virus 1 or 2, or human herpes virus 5, and hepatitis B, human papilloma virus, and molluscum contagiosum, and human immunodeficiency virus, HIV. Under the protozoal agents, Entamoeba histolytica, Giardia lambias, Trichomonas vaginalis. Under the fungal agents, Candida albicans and ectoparasites, that is the Thyrastomus and Sarcoptes scabies. These are the causative agents under the sexually transmitted diseases. So, extent of the problem, if you see, the WHO estimates 340 million new cases of syphilis, gonorrhea, chlamydia, trichomoniasis, which are occurred throughout the world in 1999 in men and women of age between 15 to 49 years. Okay, there are 350 million new cases of both all syphilis, gonorrhea, and chlamydia and trichomonas vaginalis. The largest number of new infections occurred in the region of South and Southeast Asian region, followed by Sub-Saharan Africa and Latin America and the Caribbean. The highest rate of new cases per 1,000 population occurred in Sub-Saharan Africans. Okay, these are the distribution of the sexually transmitted diseases. The extent of the problem, it is a worldwide, more than 400 million adults become infected with the sexually transmitted diseases every year. 400 million adults infected every year with sexually transmitted diseases. Four STDs that are spread primarily through the heterosexual contact are completely curable. They are Trichomonas vaginalis, Chlamydia trachomatis, syphilis, and gonorrhea. These four diseases are completely curable. And these account for 333 million STD infections, are about 80% of the worldwide total. And some 9% of all persons aged between the 15 to 44 years in the North America, which contact none of these STDs are annually, but the rate rises 25% in sub-Saharan Africa. And the Trichomonas vaginalis alone has been detected in more than 40% of women attending prenatal clinics in Uganda and Botswana. That is, these are the expanded program of the sexually transmitted diseases. In India, syphilis on serological survey in Aurangabad among 15,752 women who are attending in the antenatal clinics, 2.4% were found to be positive for the VDRL, venereal diseases research laboratory test. The women of pregnant ladies, especially the antenatal clinic, 15,752 antenatal women, among those 202.4% were positive for BDRL test. And the lymphogranuloma venereum and donor venereals are prevalent in southern states Tamil Nadu, AP, Karnataka, and Maharashtra. And if you see that epidemiological determinants, agent factor, host factor, agent factor, already I told you, protozoal, bacterial, viral, protozoal, ectoparasite, and fungal infections. And host factors, the host factors are age about 20 to 24 years of old, followed by 15 to 19 years and 25 to 29 years of age group. So you can see the STD infections, especially in 20 to 24 years of old, are followed by 15 to 19 years or 25 to 29 years of age group. Sex morbidity by infection is high in women. And marital status, commonly the sexually transmitted disease is seen in women or the men, especially in a single, divorced, and separated persons. The more number of persons will get the sexually transmitted diseases. Socioeconomic status, individual from the low socioeconomic group are prone for sexually transmitted diseases. So if you see the demographic factors, the migration of the rural to urban areas for any education or the employment or anything, the migrated people, increasing the education opportunity. Why it is more common now rather than previously? One is, number one is there is a increased educational opportunity for women and delay their marriages. That could be the one of the cause. That is education opportunities increasing in the women, and thereby because of education the marriages are delayed. And population explosion and increase in the number of young people. So population explosion and no job opportunities and increase in the number of the young people. These are the some demographic factors. So regarding the social factors, which causes these studies are the social factors are prostitution, broken homes, social disruption, social stigma, alcoholism, sexual disharmony, easy money, emotional immaturity, urbanization, and international pattern. These are the social factors. The prostitution. So the prostitution mainly the easy earning money, easy way of earning money in the prostitution. So the male partner we can call it as a prostituent, and the female partner is the prostitute. So if the prostitute is not available, not there, so there may not be any prostitutes. So we have to control the prostitutes to prevent the sexually transmitted diseases in prostitutes. Thereby, we can prevent the prostitutes and broken homes. That is, the wife and has separated wife and husbands, or any death of the other opponent partner. These are the one of the cause for the social factor for this transmission of the infection. Social disruption, the social stigma. Even though the person is suffering from sexually transmitted diseases, they are not in a position to go to the clinic or go to the hospital to treat the cases. That is the social stigma. So they may be drop out in the middle, they may attend to the quacks, so they may to have the irregular or incomplete treatment. So this is a social stigmatized disease. So social stigma and alcoholism itself is a one part which provokes the sexual the harmony. So that is the alcoholism and sexual disharmony, and then easy money and the emotional immaturity and urbanization, international travel from other countries. So in developed countries, these prostitutes can be called as a time that is a good time girl. They will call as a good time girl. So in in developed countries, so these are the factors to spread the sexually transmitted diseases. If you see the risk factors for the sexual STDs are engaging in sexual activity when either partner has unhealed lesions. So if the partner is having the unhealed lesions, they are they are they may spread the infection to the opposite partner. So that is engaging the sexual activity when either partner has unhealed lesions or rectal or vaginal irritation or infection, or sexual activity that may damage the mucosal lining, and the tampons or the vaginal dryness, that the tampons that are used, and then vaginal dryness. These are the risk factors for the STDs. And if you see clinical spectrum, the clinical spectrum, that is, we can call it as in syphilis, it is a primary, we can call it as the chancre, and the secondary rashes, and the latent asymptomatic and the tertiary gummas. So in syphilis, so if you treat in a primary stage, so it will be subsided completely. We can easily completely treat it. But in secondary means the people will develop the rashes all over the body, and latent means asymptomatic, and tertiary means forming the gummas and the genitalia. So you can see the primary chancres of the syphilis, the site of the infection, and the secondary syphilis, that is the rashes on the palms and the hands. And gonococcal infection. If you see the symptoms of the gonococcal infection, there is a purulent discharge from the genitalia. So the patients will complain of purulent discharge from the genitalia and burning sensation, and during the urination especially, there's a burning sensation during the urination and conjunctivitis. Okay, these are the for the gonococcal infection the symptoms. And the trichomoniasis in females, there is a greenish yellow frothy vaginal discharge. And if the woman is suffering from trichomoniasis, prone for having the preterm deliveries and the low birth weight babies. So trichomoniasis vaginalis in females, they complaints of greenish yellow frothy vaginal discharge, prone for in antenatal prone for preterm deliveries and the low birth weight. If you see the gyms stand for the culture and the pap smear for the manifestation in the pap smear in the infestations of the trichomonas vaginalis. So in complication in females, pelvic inflammatory diseases and the cervicitis, and in males they will complaints of they will have the urethritis and the prostatitis, and in both there may be a fertility or reproductive system problems. Infertility in the woman, they may have infertility and reproductive system problems. And then infants infected, if these STDs are infected in the womb or during the pregnancy, they may lead to stillbirths, blindness, and permanent neurological damage. So there may be a stillbirth, there may be conjunctivitis, it leads to blindness and permanent neurological damage. Okay, before going to the control of STD, I would like to tell regarding the syndromic management of the sexually transmitted diseases. Here, because the syndromic management itself is a short notes for you. So, whenever the question is asked regarding the syndromic approach of the sexually transmitted diseases, so you have to write under the six headlines. That is syndromic approach in the STDs. That is the it is a scientific derived approach offer the accessible and immediately treatment for the affected person, and management of syndromic sexually transmitted diseases are according to the following types. There are six types of syndromic approach management for the sexually transmitted disease. One is syndromic management of urethral discharge, syndromic management of urethral discharge, syndromic management of vaginal discharge, syndromic management of lower abdominal pain, syndromic management of inguinal BIVO, syndromic management of scrotal cilia. So under these headings, you will have the syndromic management. So whenever they ask the question regarding the syndromic management of the sexually transmitted diseases, you have to write in detail regarding the syndromic management. Okay, that is first one is the syndromic management of the urethral discharge in the males. So here, first of all, you have to ask regarding the discharge in the males. So if the patient complains of discharge in the males, you have to you have to examine thoroughly. And the treatment for the urethral discharge is cefixime 400 milligrams orally, single dose, followed by azithromycin 1 gram orally, and advised to return after 7 days. If the discharge or dysuria persists, tablet scandazole 2 milligrams, you have to do tablet scandazole 2 milligrams orally. And then the syndromic management of vaginal discharge. If the woman complains of syndromic management of vaginal discharge, you have to examine the vaginal discharge. So, is there any vaginitis or cervicitis? So, you have to ask first history of menstrual cycle to rule out the pregnancy. Of course, in pregnancy there is some discharge we can see, but if there is a profuse discharge, first of all you have to rule out whether she is pregnant or not, and then you have to rule out the type of discharge, how it is, and then you have to take the history of burning micturition and for any ulcer. So, is there any history of burning nutrition? So, history of type of discharge, and may you have to rule out the pregnancy. First of all, you have to examine vaginally. So, here, if it is a trichomonas vaginalis, the discharge is greenish frothy in appearance. If it is a candidiasis, the discharge is curd white appearance. If it is a bacterial vaginitis, the discharge is adherent discharge. And if it is a cervicitis, you have to look for cervical erosion. So these are the simple types. You can easily identify whether the patient is suffering from trichomoniasis, candidiasis, or bacterial infection. If it is greenish frothy appearance, it is a trichomoniasis. If it is a white curd appearance, it is a candidiasis. And if it is adherent, it is bacterial infection. And besides, that is either it may be a vaginitis or a cervicitis. If it is a cervicitis, you have to look for cervical erosion. And laboratory investigation for this case. So, with emulsion, you can look for the Trichomonas vaginalis or grams, and you can look for the other bacterial infections. The treatment for the Trichomonas vaginalis and vaginitis, and the treatment for the Trichomonas vaginalis plus bacterial vaginitis or candidiasis, we have to give skindazole 2 milligrams orally or tinidazole 500 milligrams BD for 5 days and metoclopramide to prevent emesis. For cases, you can do fluconazole 150 milligram orally, and then local application of clotrimazole and 500 milligrams pessary. That is the treatment for the vasinitis. That is kindazole or tinidazole and metoclopramide to prevent the gastric irritation or vomitings, and then the local application of clotrimazole pessaries. And for the cervicitis, you can give ceflexin 400 milligrams and azithromycin 1 gram, and then avoid dosing. Whenever the patient is complains of any discharge, you should not dose the vagina. Previously, they used to tell that the dosing of the vagina, but nowadays they are not telling for the dosing of the vagina because the infection may spread up towards the fallopian tubes, etc. And the management in the pregnant, if the woman is pregnant in the first trimester, you should not give any tablets orally, only local application in the form of pessaries. If in third trimester, second and third trimester, you can give skindazole 2 grams single tablet and tindrazole 500 milligrams BD for 5 days and metoclopramide to prevent gastric irritation and metronidazole, etc. That is regarding the vaginal discharge. Whereas in the management of syndromic approach in the management of lower abdominal pain, whenever the patient complains of lower abdominal pain, so the commonly you can see the agent is gonococcal infection or candidiasis. That is a it may be in the form of Neisseria gonorrhea, or it may be in the form of clinidiasis. And then you have differential diagnosis. You can go for if the patient is complaints of lower abdominal pain, you have to find out the differential diagnosis in the form of either it may be a ectopic pregnancy or a twisted ovarian cyst or any appendicitis or any amoebiasis. We have to differentiate the lower abdominal pain. And then history for the trichomonas vaginalis, you have to take the menstrual history, and then there may be a dysmenorrhea and there may be a lower abdominal pain, severe pain. The examination, general examination, in detail of the general examination and pervasive examination. In pervasive examination, take the slide, look for the grams too. So the treatment for the lower abdominal pain, that is the cefixime for 7 days, 400 milligrams BD, and plus doxycycline 100 milligrams BD for 2 weeks with metronidazole 400 milligrams BD for 14 days. So lower abdominal pain, you have to give cefixime 400 milligrams BD for 7 days, doxycycline 100 milligrams for 2 weeks, and metronidazole 400 milligrams for 14 days. And you have to treat the partners also. Otherwise, she will be all right, but she may get again the infection from his partner. Again, management of the is a syndromic approach of the management of the genital ulcer. Okay, I have told already the urethral discharge, vaginal discharge, and the lower abdominal pain, and the fourth one is management of the genital ulcers. If the patient is having the genital ulcers, you have to look for maybe the causative agent is Trichomonas pallidus or Haemophilus dictybacilli or Klebsiella granulomatous and and herpes simplex. So you have to take the history of ulcers on the genitalia. So how the ulcers are formed. So you have to examine is the ulcer is painful or painless. If it is painful ulcer, it may be the herpes that is viral infection, that is herpes simplex. If it is a painless ulcer, it may be for the if painless and a short lymph nodes, you can think of the syphilis. And if it is a severe painful with a single ulcer, you have to you have to think of chancroid. So that is one is a painful ulcer in the herpes simplex, painless ulcers, short in lymph nodes in the syphilis, and painful ulcers with a single painful ulcers that is chancroid. And then laboratory diagnosis, you have to look for RPR, test for the syphilis. And regarding the treatment, you have to treat vesicles or ulcers. Any vesicles or ulcers, you have to treat for this. And the treatment is azithromycin TID for 7 days. That is a 400 milligrams TID for 7 days. And no, the vesicles you should not rupture the vesicles. If at all there is any reason, you have to think. And then in syphilis, you won't see the any vesicles. So for the treatment of the syphilis is benzathine penicillin 2.4 million international unit. Plus, if the patient is sensitive to penicillin, you can go for azithromycin 1 gram as a single dose and ciprofloxacin 500 milligrams BD for 3 days and treat all the partners. And regarding the management of the scrotal swelling, so sometimes you can see these scrotal swellings. So here the management is the causative agent is it may be due to Neisseria gonorrhea or it may be due to chlamydia trachomatis. Now I have to differentiate the with the scrotal swellings with the gonorrhea and chlamydia. That is differential diagnosis is it may be due to tuberculosis, it may be due to filariasis, or it may be due to mumps infections, or it may be due to trauma. The scrotal swelling we have to differentiate with the tuberculosis of the epidermitis and then filariasis and the mumps and the trauma. And on examination, the swollen scrotum, you have to look for the scrotum examination. Here, and then the treatment is cefixime 400 milligrams BD for 7 days plus a doxycycline 400 milligrams BD for 14 days. And if the supportive bandage, you have to apply supportive bandage for the scrotal swelling. And you have to treat the partner. And regarding the management of the inguinal lymph nodes, that is the last one, the syndromic approach of management of inguinal lymph nodes. Here, the constituent agent is it may be the Trichoma vaginalis or Chlamydia trachomatis or Haemophilus bacilli. These are the causes for inguinal lymph node enlargement. Here, the differential diagnosis is it may be we have to differentiate it mycobacterial tuberculosis or filariasis and malignant or any injury of the lower limbs or any ulcers on the vagina or any furuncles on the vaginal region or any furuncles on the genitalial region. There may be enlarged inguinal lymph nodes. You should not be confused with the sexually transmitted diseases for all the lymph nodes which are enlarged or enlarged lymph nodes in the inguinal region. It may be due to injury to the or ulcer on the lower limbs, maybe due to any furuncles or the hair follicle infection or any ulcers on the genital region. So here we have to take the history. Is there any painful swelling? There is any history of sexual exposure and history of fever. You have to ask the history of pain. Is there any painful swelling? Is it a painful inguinal swelling? Is it a history of sexual exposure? Is there any history of fever? And for the treatment is doxycycline 100 milligrams for 21 days plus azithromycin 1 gram single dose and ciprofloxacin 500 milligrams BD for 3 days. And if the BIBO is present, you have to do IND in the primary. He can do IND in the primary health centers. If there is a BIBO, you can do IND in the primary health center under the antibiotics. Otherwise, the sciences will fall. So that is the syndromic management in sexually transmitted diseases. So whenever they ask the syndromic management, you have to you have to write all these things, 6 points in detail regarding the syndromic management and regarding the control of STDs, initial planning, intervention strategies, support components, and monitoring evaluation. Sometimes they may ask the control of sexually transmitted diseases. Here, initial planning, intervention strategies, support to components, and the monitoring and evaluation. Here, initial planning. Initial planning means, first of all, the problem definition in terms of prevalence, psychological, and other health effects by seroepidemiological and population survey. So we have to take the problem definition. Initial planning means the problem definition in terms of prevalence of infection, psychosocial type, and other effects of seroepidemiological. You have to do seroepidemiological survey and population survey. Here, and then establish the priorities. It depends upon the health problem consideration. How it depends upon the magnitude of the problem in that community and consequences of the problem in that community. And the second one is feasibility of the control. How best we can control the infection. That is availability of resources. That is there. So first of all, you have to take the priorities regarding these diseases, and then setting the objectives. So the objectives it may be measurable and achievable. The objectives may be unambiguous and quantifiable. The objectives should be measurable objectives and achievable objectives and unambiguous and quantifiable objectives. And considering the strategies. Here, intervention strategies. So, what are the intervention strategies? That is case detection in the form of screening, contact tracing, cluster testing. So, first of all, case detection in the form of screening. So, case holding and treatment, epidemiological treatment, prophylaxis in the form of contraceptives and vaccine, and health education. So, here, case detection. How you are going to do a case detection by screening. By screening the healthy volunteers from the general population are tested for early detection of diseases. First of all, case detection is you have to screen the healthy volunteers in the general population and they tested for early detection of diseases. High priority groups are normally you have to screen the high priority groups. The high priority groups are pregnant women, so that is in all antenatal group, all the antenatal women, we have to test for blood for VDR. That is pregnant women and the blood donors. Blood donors. So for all the blood donors, we have to do VDRL test. And industrial workers. So all the industrial workers, we have to look for the screening in the industrial workers and the prostitutes. All the prostitutes we have to do VDRL test and the restaurant and hotel staff. That is regarding the screening of the healthy volunteers along the general population. And contact tracing. Contact tracing means it is a technique by which the sexual partners of the diagnosed patients are identified, located, and investigated and treated. So, if the person is suffering from any sexual diseases, we had to treat that person, and also we had to trace out the sexual partners. So we had to ask the questions, who are the contacts for this? Because especially in the Southeast Asian region, in the Indian country, they are very much fear, there are very much stigma regarding the telling the contacts of the sexual partners. Whereas in developed countries, you can easily trace out just by taking by telephoning those people. We, we can trace out the contacts. Patients are interviewed for their sexual partners by specially trained staff. We have to we have to interview the patients for their sexual partners by specially trained staff. Cluster testing, that is, patients are asked to name the persons of either sex who move in the same socio-sexual environment. They will have to ask the patients to name the other persons of the either sex who are moving in the same socio-sexual environment. And case holding and treatment, adequate treatment for the patients and their contacts is the mainstay of STD control. So adequate treatment, you have to give complete treatment to the patients and also their contacts. That is the main program for this. That thereby we can control the STD. And every effort should be made to ensure the complete and adequate treatment. Treatment should be complete and it should be adequate treatment. And epidemiological treatment, also called as contact tracing. That is, the persons who are recently exposed to STD are administered with a full therapeutic dose of treatment. Persons who are exposed to sexually transmitted diseases are administered full treatment for the case, and it must be combined with venereological examination and contact tracing. So, even though we have given treatment, we have to do venereological examination and contact tracing. Personal prophylaxis with contraceptives. Sometimes the personal prophylaxis may prevent the transmission of infection. Mechanical barriers like condoms, diaphragms are recommended. Even though if you are giving the treatment for the sexually transmitted disease cases, you have to advise to use the condoms or the diaphragms for about 14 days to prevent the further infection. These barriers methods to minimize the risk of sexually transmitted infections when used with spermicide. And health education aim is to help the individuals to alter their behavior in an effort to avoid sexually transmitted diseases. So health education is very important. So you have to educate the people to alter their behavior, and you have to concentrate on the target group, including priority groups, patients, and general public. And supportive component means STD clinics, laboratory services, primary health care, information system, legislation, and social welfare measures. Here, the STD clinics means we have to allot the STD clinics in every area. All the drugs should be available in the STD clinics, and STD clinics should be of a long duration. And the for the STD clinics are from morning to evening. So, because of social stigma, the people may not attend in the in sometimes. So they are really having some shy to attend the clinics. So STD clinics should be available in everywhere. All the drugs should be available in the STD clinics, and it should be maintained from long timings. And laboratory services, health centers, primary health centers. The laboratory services should be available in all the primary health centers. And the primary health center the workers should manage the treatment. So if the STD clinics are not available in time, they may go to the cracks and they may have an irregular treatment or incomplete treatment. They will be resistant to the drugs. The information system should be available, and the legislation means, so some traffic accident, it's a immoral traffic accident. Previously in 1956 they called it as the Sita Act, that is Suppression of Traffic Immoral Act. So of the application of the legislation, so if at all any woman or a person, lady was assassinated by these sexually transmitted diseases cases persons. So you have to take the severe action on those persons. That is the immoral traffic act. And then social welfare measures. So avoiding regarding the social welfare measures and national AIDS STD control program. The National STD Control Program in India was started in 1946 with the arrival of spread of HIV infection in the country, and it was brought under the purview of National AIDS Organization in the year 1992. So in 1992, the STD control program was emerged into the National AIDS Organization. So objectives of this program is to reduce the sexually transmitted diseases. Thereby, we can control the HIV infection transmission by minimizing the risk factor and prevent the short-term as well as the long-term morbidity and mortality due to sexually transmitted diseases. Prevent the short-term as well as the long-term morbidity and mortality. So, in order to accomplish these objectives, the following strategies have been imported in the strategic plan for the prevention of STD control. So strategies are the broad spectrum for the controlling the STDs as outlined in the strategic plan for the prevention and control of STD, control of AIDS. One is adequate and effective program management, and the second one is prevention and transmission of STD and HIV infection through IEC and promotion of that is information education and communication and the promotion of safer sexual behavior by the use of condom. That is the health, especially the health education by use of condoms. You can prevent the STD and HIV infection. That is safer sexual behavior and adequate and comprehensive case management, including diagnosis, treatment, and individual counseling, both the patients and the partners notification and the screening for the other diseases, increasing the access to health care for the sexually transmitted diseases by strengthening the existing facilities and the structures and creating the new facilities wherever necessary. So the access for the STDs in the healthcare, primary healthcare, thereby we can strengthen the existing facilities in the primary health centers. There are more number of workers in the primary health centers, especially you can utilize the ASHA workers or multi-purpose health workers regarding the treatment and catching the STD patients. Early diagnosis and treatment, mostly the asymptomatic infection through case finding and screening. So, early diagnosis and the treatment regarding the asymptomatic patients. And the treatment should be complete treatment. If the patient was diagnosed, you can find out the contacts of the patients. Thereby, you can give treatment to the both persons. Actions are the following measures. Major actions have been taken along the lines suggested in the strategies. The training of the healthcare workers in both public and private sectors in comprehensive STD case management, development of appropriate laboratory services for the diagnosis of STD, and conduct the microbiological, social behavior, and operational research and the surveillance to assess the epidemiological situation and monitor and evaluate the ongoing STD control program. These are the actions regarding the STD control and AIDS control program. Okay, and then that is the regarding the complete STD and AIDS control program, complete regarding the STD diseases and treatment.